Hello, my name is Ashley Linder. I am a sophomore at West Virginia University doing research with the WVU Institute for Community and Rural Health on the Accountable Health Communities model of addressing social needs. Health-related social needs, such as food insecurity, housing instability, and lack of transportation, are indicators of the growing gap between clinical care and community service providers. This study was introduced by the Center for Medicare and Medicaid Services to support community efforts to address the health-related social needs of Medicare and Medicaid beneficiaries. The Accountable Health Communities model tests the practice of addressing health-related social needs as part of clinical visits, with the goal of resolving Medicare and Medicaid beneficiaries' needs. This study could improve beneficiaries' quality of life overall by helping them address their needs, as well as decrease the rate of preventable hospitalizations that are the result of health-related social needs not being met. WVU's Ruby Memorial Hospital was one of many clinical sites where the Accountable Health Communities model was tested. Eligible patients were screened during their emergency room visits using a screening tool developed by the Center for Medicare and Medicaid Services for core and supplemental health-related social needs. Core needs were housing stability and quality, utility needs, safety, food security, and transportation. Supplemental needs were untreated physical or emotional disabilities. The patients were eligible for screening if they were a community-dwelling West Virginia resident and a Medicare, Medicaid, or CHIP beneficiary. Eligible beneficiaries were considered high risk and entered into the study if they had visited the emergency room 2 or more times in the past 12 months and screened positive for 1 or more core health-related social needs. High-risk patients were randomly assigned to either the control or intervention group. 30% of high-risk patients went into the control group and 70% went into the intervention group. The data was collected by the Partners in Health Network, which is the bridge organization overseeing the implementation of this model in West Virginia. The control group in this study received a community resource summary with referrals to services near them that could help them resolve their needs. The intervention group was also sent this community resource summary, but they were also contacted by a navigator who could answer their questions by phone and assist them in resolving their needs by contacting community service providers on their behalf. From the emergency department at Ruby Memorial Hospital, we collected data from 265 eligible beneficiaries. This table shows the demographic information of all the eligible beneficiaries we screened. It's notable that in the insurance category, we screened an equal number of Medicare and Medicaid beneficiaries. This graph shows the total number of each category of social needs cited by the high-risk group. The top bar of the graph labeled disability was the supplemental needs category, while the bottom 4 were the core needs that determined high-risk status. This last figure shows the status of the cases opened by the navigators for each of the needs cited by the high-risk beneficiaries in the intervention group. Navigators were able to successfully resolve the beneficiaries' needs in 58% of cases, and 29% of cases are still open. So in the big picture, of the beneficiaries we screened, we found that 59 were high risk, and of those 59, 76% of them were Medicaid beneficiaries. So that indicates that this systematic screening is catching beneficiaries who are highly vulnerable due to their social needs. The results of the screenings for high-risk beneficiaries showed that transportation is the most common need. When answering questions from the screening tool, 31 beneficiaries reported that they could not reliably reach their work, medical appointments, or other essential places. 26 beneficiaries could not or were concerned that they could not afford sufficient food in the past year, and another 26 either did not have steady housing or their housing had problems such as pests, mold, or water leaks. There were also 22 beneficiaries who reported that they needed help paying their utility bills, citing that their utility companies have threatened to shut off their services in the past year. This indicates that among high-risk beneficiaries, there is no single category of core needs that is overshadowing the rest, or one that's being sufficiently met across the board. Navigation is such a crucial part of this study because it's what's directly affecting the beneficiaries and possibly leading to lower healthcare spending and emergency room usage. From this data set, the majority of cases were resolved, which is a good sign for the effectiveness of the model in providing a link between beneficiaries and community service providers. Successful resolution of the majority of cases indicates that identification of high-risk beneficiaries in a clinical setting can lead to positive outcomes. The Accountable Health Communities model's implementation at Ruby Memorial allowed navigators to reach high-risk patients, answer their questions, and direct them to services to help resolve their case. In terms of future research, we will be looking at the impact this model has had in West Virginia specifically, which will involve analyzing all of the data that's been collected at every screening site in West Virginia and interviewing participants in the model. We will be using that information to try to identify geographic locations in the state where resources are not sufficient to meet the health-related social needs identified by this model. We will also be looking at the referral process and how communication and relationships between administrators affected the model. And since we have screening data collected prior to the pandemic and screening has continued over the past year, we will be able to look at how COVID-19 has affected the outcomes and needs of beneficiaries. These are the references used in this presentation. And just a quick disclaimer, this poster was supported by the Centers for Medicare and Medicaid Services of the U.S. Department of Health and Human Services as part of a financial assistance award totaling $2,505,942.30, with 100% funded by CMS HHS. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by CMS HHS or the U.S. government. There are also several people listed here that we would like to thank for their contributions to this project. And thank you all for listening, and please feel free to leave any questions in the comments.